We know now that pain is 100% of the time produced by the brain. All pain, no matter how it feels, sharp, dull, strong, mild, or how long you've had it. In cases of acute pain lasting a few weeks or months, it's usually an issue with tissue damage, like a back injury or an ankle sprain. And generally, we give the advice to stay active and gradually return back to normal. And these people generally do really well with therapy. In other cases where pain lasts 3 months or more, it's called chronic pain. And this type of pain, tissue damage is not the issue. What's less clear is when pain becomes chronic, what's the best thing to do about it? Having a brain that keeps on producing pain even after the tissues are restored and out of danger is no fun for the patient or even for us as clinicians. Some people say it feels like there must be something wrong with them, but we know that most tissues heal after 3 to 6 months, and ongoing pain becomes less about the structure in the body and more about the sensitivity of the nervous system. In other words, it's more complex. So to try to figure out what's going on, we need to retrain the brain and the nervous system. And to do this, it's helpful to look at all the things that affect the nervous system. Let me see if I can get this timed right. So, before we talk about everything that can contribute to the nervous system, there's this famous pain story that was in medical literature. It's a true story about the nail in the boot, and I don't know if anybody's heard about it, but basically it's a construction worker. He was working on a construction site, and he jumped off a small ladder and stepped on a long nail that went right through his work boot. So the minute he saw the nail through the boot, he had the most horrific pain. He was taken by an ambulance, he was sedated, and even with the most intense narcotics, the pain was unbearable. And this is a true story, like this is in literature, you can look it up. Finally, they were able to cut the boot off, and they found that the nail was stuck between his 2 toes. It never even penetrated his skin. There was no injury, nothing wrong, but he was experiencing excruciating pain. And so why is this? It's because of the perception. The brain evaluated this and produced a pain response based on its visual perception, even though the tissues had very little to do with it. So the bottom line is that tissues heal really well, but pain can go on and on and on. And many of our patients come in with back pain, and you ask them, when did you hurt it? And they say 30 years ago. Well, we know tissues heal, but then why does the pain persist? So we have to learn more about how pain actually works. So our body has a living, breathing alarm system called the nervous system. We have 45 miles of nerves in our body, and the nerves are always buzzing along at a resting, the graph, you can't really see it, but they're always buzzing along at a resting threshold. And when they get excited, they reach a threshold and fire a message. We refer to this as an action potential. The nervous system is an alarm system, and it will actually send a message on. But it isn't just a tube that sends messages from A to B. The nervous system is the most sophisticated system. And we've identified that there's hundreds of ion channels in our nervous system that are sensitive to temperature in the environment. There's channels that are sensitive to the amount of stress we experience. There's channels that are sensitive to movement or even immune function. So the nervous system has the ability to enhance or even decrease some of the impulses coming its way. When you damage a nerve, you can see this image here, it strips away the protective layer that's called myelin, the myelin sheath, and then ion channels that are sensitive to movement, temperature, pressure, immune function. These ion channels will insert themselves into that area, and your nervous system can become super, super sensitive to that stimulus. So what does that mean to us as clinicians? When a patient comes in and says, the left side of my neck feels hot, or when it's cold outside, I feel my back more. It actually can happen, and it does happen. And why? Because the sensors are sensitive to temperature. Or another example is when people get sick, like they're doing really well, and then all of a sudden they come down with a UTI or COVID, and then suddenly their back pain is so much more pronounced to when they first started. That's a real thing, and it's because those ion channels in that area where they have back pain or there was injury are sensitive to immune function. So you can kind of, as therapists, we can have the power to make sense of this to them and help calm the nervous system down. So overall, you cannot have pain without the brain. This also means that it's possible to use our brain to reduce pain. but our brain isn't under full conscious control all the time, so we can't simply wish pain away. There may still be physical triggers for pain, but we need to recognize how the brain can alter our experience of pain. So before we go into how to alter pain in our patients, let me just explain how the nervous system can become sensitive in patients and what the concept of central sensitization really is. Because I'm sure you guys have heard it, but something really important happens here in the dorsal horn of the spinal cord. So this is a cross section of the spinal cord at one level, and the dorsal horn is where information comes from the periphery. So if I were to step on your foot, the information fires from your foot and it comes into the dorsal horn. So in school we learned that there's A fibers and C fibers. A fibers are light touch and C fibers are danger fibers. They're not pain fibers. We don't experience pain in our arm or in our back. We experience pain in the brain. So you cannot call a C fiber a pain fiber because it's simply not. And so when C and A fibers come in from the periphery, they come into the dorsal horn of the spinal cord, and before they send a message to the brain, there's an intermediate neuron called an interneuron. The simplest way to think of an interneuron is the bouncer at a nightclub, sort of like the gatekeeper that you have to get through to get into the brain or into the club. Through neurochemical interactions, the interneurons block most information. Simply put, when light touch fibers, the A fibers, come through, the interneurons mostly block that information so that you're not flooding your brain with unimportant information. So example would be like my pants are touching my thighs. I can feel that, but my brain is blocking that information because it's not necessary for me to be aware of this. So that's why the interneurons normally block that information. When danger fibers come in, typically they allow that information to pass through to the brain and say, danger, there's something going on with your knee, for example. When that information passes through, there's something called a second order neuron, and they're the ones that send the signal, danger, danger, there's something going on at the knee. Notice that there's also an arrow going down, so the brain can also decide to pay attention to that information or shut it down. All of us have stubbed our toe, and it doesn't hurt for months. It hurts for a couple of minutes, and then the brain turns that signal down and says, calm down, you're gonna be okay. And we've all experienced that, right? So in central sensitization though, this is different. The central nervous system is getting bombarded with C fibers, the danger fibers. When C fibers hammer in, it kills out that interneuron, that gatekeeper, and high levels of amino acids cause interneurons to shrivel up and then they die out. Now information comes straight through to the brain. Notice that light touch, the A fibers, now have a pathway straight to the brain. So now light touch is bombarding the brain. The brain gets their threat levels to go up, and you start to produce pain in the presence of light touch. This is a term we call allodynia. So the next time you're working on your patient's lower back and you're barely applying pressure, but they're jumping off the table, you can explain to them that their pain is very, very real. There's bombardment of the central nervous system, and there's an upregulation in their pain. Now, central sensitization, I'm sure you've seen that term in our evaluations, but these are just some clinical presentations. There's no diagnostic test to be like, oh, you are central sensitization, but you can kind of pick out what patients really would benefit from pain neuroscience and which ones wouldn't. Now, the next slide. It's important to really know that to individualize the pain experience, and this picture is just a map to show that there's no one place in our brain that pain is produced. There's actually 9 key areas that talk to each other during the pain experience, and this is why every person's pain experience is unique to them. So environment, situations, their individual makeup, stress, contributors, all of these things can increase or decrease the pain experience. Now, what do patients really want out of us? They want a clear diagnosis, they want education about their problem, and really they just want pain relief. So research shows that the more you know about pain and how it works, the better off you'll be. Pain is much like encountering a lion. Imagine that you're in a room and a wild African lion enters. Your nervous system is going to go into a fight or flight response or a stress response for survival. Persistent pain can feel like a lion is always in the room. Now imagine having more knowledge about lions. You're a lion trainer and have learned how to handle the lion. That's like pain too. The more knowledge you have about pain, your contributing factors and how to actively manage it, well, the lion becomes more like a cub. Your stress response goes down, and in turn, you'll hurt less. There's several other examples to explain pain, but this is a really good one that just resonates with people. These are some things that patients already hear all the time, and we know that the more we talk about these in the way that they already know that they're bone on bone. We don't need to encourage that type of language, and actually what it does is it may increase fear in patients, and in turn it's going to increase their pain. So our job is really to help desensitize a hypersensitive nervous system. So we already know that there's gold level evidence that movement and exercise treat persisting pain. But what else can we be doing to assist in desensitization? Basically, there's this water cup analogy, and I don't know if you guys have heard about it, but basically it's like pain is an overflowing cup of water, and so there's so many things going on, and they don't know how to manage their pain, so the water is overflowing from the cup. Now, as therapists, we can help manage that by bringing the water down to a tolerable level. And so part of the strategy of pain management is to reduce stressors in your cup. The cup will never be empty. You'll have to build some skills to handle what's in the cup, but improving knowledge about pain contributors, addressing tissue issues, having a positive mindset, regular exercise, stress management, improved sleep, nutrition, and other health habits can help patients build resiliency. So just to go through quickly, improving knowledge is just talking about pain to patients and getting them to understand it can be really helpful. Along with a positive mindset, there's research that shows people that have a positive outlook on physical therapy tend to have a better outcome, and those that have a negative belief about physical therapy tend to have a negative outcome. So just giving them that information can make them more aware. Same thing with tools for stress management. We do diaphragmatic breathing. There's so many tools for meditation, and just like taking a walk, we already encourage that. Regular exercise, sleep, and nutrition. I'm not a nutrition expert, but we can just give them general knowledge that there are foods that increase inflammation and that there's foods that can help fight it. So just getting them aware of these things can really help them through their symptoms. So how do we overcome pain? As Adrienne Lau says, and a lot of my work is from Adrienne Lau's studies, that there's 4 pillars to overcoming chronic pain. So the first one is pain neuroscience education. Patients need to understand how pain works in the body for them to overcome it. Number 2 is cardiovascular or aerobic exercise. Now, there's a certain level of getting to that cardiovascular zone that helps decrease the stress hormones in your body and increases the happy hormones. And basically, it's working out at your 60 to 80% of your target heart rate. But I find that kind of tedious and like a nuisance to calculate. So the best way to think about that is how hard are you breathing? So our PE scale is 6 to 7 on this, and basically you just measure how hard am I breathing. You want to be breathing heavy. You could hold a conversation, but you really don't want to. And that's when you know you're appropriately challenging your aerobic or cardiovascular system. Sleep. Ideally, we want adults to be getting 7 to 10 hours a night. And then number 4 is goal setting. So if patients don't have goals that they're working towards, then there's no reason why they're coming here. So goal setting is super important for us to know, why are you here and what are we helping you overcome to achieve those goals. So those are the 4 pillars, and taking all of this content and putting it in a patient formal language that they can actually understand is really what pain neuroscience is